Just curious, how many of you guys actually do vertebroplasties? Raise your hand. Okay, and how many of you do kyphoplasties? Okay, pretty good number. In reality, I think the most common use of this is osteoporotic vertebral compression fractures. Incidences upwards of up to 500,000 per year. The reason why we do this is for fracture stabilization and relief of pain. And as you know, this started off as a radiology procedure. And I would say that maybe about 10 years ago, it really started shifting back towards a surgical procedure when kyphoplasty was introduced. But I would say that maybe that pendulum is sort of shifting the other way more recently. But there is sort of this ongoing debate on whether or not this is actually a surgical procedure versus an IR type of procedure, whether or not you should actually reduce the fracture, the importance of that or not, and the incidence of complications. And I would say the biggest one that we deal with the most are probably extravasations, and I'm talking about more dorsal extravasations into the spinal canal. And I'm sure that many of you have had to sort of bail out some of our partners who are either pain management specialists or interventional radiologists who are doing the procedures, and then they ended up with extravasations within the canal and the foramen. The incidences can be as high as 30 to 70% in these sort of procedures. So why do these compression fractures occur? It's the largest reason why it occurs is because of oral steroids. Early menopause is the second, and then unintentional weight and loss and malnutrition. And I'm talking about these other factors. So the other factors also include tumors as well. And where do these fractures typically occur? In reality, if they sort of have a bimodal distribution, you can see that it occurs sort of in the mid-thoracic spine, typically where the kyphosis is. And as you know, the worse that a kyphosis gets, the more anterior loading there is, and that can actually sort of make the osteoporotic compression fractures even worse. And the second area where this occurs quite commonly is the thoracolumbar junction because of the loads that are placed between the very stiff thoracic spine and the very mobile lumbar spine. So the origin of the vertebroplasties started with vertebral angiomas. And this was way back in 1987. And then as the interventional radiologists started using these for vertebral metastases and found pretty good pain relief for this procedure. And it really wasn't until early 2000 when people started using these for vertebral compression fractures. This was a report in Spine in the year 2000. So what types of complications are most common? I would say the ones that we are most concerned about, the first one is pulmonary embolism. Multiple studies showing that the cement can actually embolize into the pulmonary vasculature. And then the second one that we are as spine surgeons concerned about is neurologic injury, both in the central canal as well as lateral recess and or even the foramen. So this report in JBJS talked about the leakages that occur in vertebroplasty patients. So they did a plain film and CT analysis of 76 VCFs in almost 50 patients. And the CT revealed extravasation 1.5 times more frequently than the X-rays. And we'll sort of go over some of the studies that I did during my fellowship. But the most common extravasation occurred through the base vertebral venous system in the segmental veins. So 93% and 86% respectively. And this was often missed or underestimated on plain film, and only 7% of these leaks into the spinal canal were correctly diagnosed with the X-rays. So if you're only relying on a lateral X-ray in order to determine whether or not there's extravasation into the spinal canal, it's really not sufficient. So this is what can happen, and I'm sure that many of you have seen X-rays that look like this, and this is actually an example of some cement that was extracted following a procedure like this. You can see that it extravasated into the posterior canal. So what are some of the factors that influence intracompartmental cement filling and extracompartmental extravasation? And again, this was a study that I did at the Hospital for Special Surgery. But what we were looking at were both patient-dependent factors, number one, and then physician-dependent factors, because they're both very important. The patient-dependent factors primarily had to do with their anatomy. That's their bony anatomy, their vertebral body configuration, and whether or not there's any disturbance of any of the cortical structures, as well as the vascular anatomy. And we talked about some of those as well. Some of the physician-dependent factors really had to do with the consistency of the cement. And as you know, for those of us who are orthopedic surgeons, we use quite a bit of cement in other applications, specifically total joints and sometimes in trauma and infection as well. But it's the consistency of the cement that sort of dictates whether or not it actually is viscous enough not to extravasate. And then it's the volume of cement within that given volume within the vertebral body, and then the rate of the cement fill. And then we'll go over that in just a little bit, but that's how quickly the cement is introduced into the vertebral body. And then finally, it's the location of the needle at the time that the cement is introduced into the vertebral body. So this is just some basic anatomy, looking at the anterior external venous plexus and the anterior internal venous plexus. And it's this vein right here, the basivertebral vein, that really just pulls into the vertebral bodies from the canal itself. So when you take a look at it from a cross-sectional perspective, you can see that perhaps the cement that's extravasated anteriorly could potentially turn into pulmonary embolism. But it's really the cement that's extravasated posteriorly, primarily through the basivertebral system, that goes into the spinal canal and affects neurologic function. So we took a look at thoracic and lumbar vertebra. We injected it with this radiopaque cement that you could actually deliver a consistent volume over time. So every turn, we would introduce 0.25 cc's per turn, and then we measured the injection time. And so what we looked at was the volume of the cement that was delivered divided by the time. And then we took 3D reconstructions or 2D reconstructions of the CT scans, and then analyzed them both radiographically as well as the anatomy. We took sections axially through the mid portion of the vertebral body, and then took two separate mid-sagittal sections, one on the left and one on the right. So this is axial cut, and then we made two right sagittal and left sagittal cuts. And this is what some of the filling patterns look like. So as you can see here, the cement fill percentage, we took a look at the volume of the cement itself relative to the vertebral body. And so that was a cement fill percentage that we obtained. And then we took a look at the different zone classifications on where the cement was located. The two anterior zones, left and right, would be anterior, and then the 3 and 4 would be posterior, and the posterior zone on axial cut. And so this is another example of what the cement looked like at T9. And you can see that this filling pattern primarily filled at zones 2 and then zone 4. And you can see that there's a little bit of cement in the spinal canal here as well. So this is just some of the results. On the axial view, you can see that consistently. So this is the specimen measurement, and this is a CT scan measurement. Almost at every single level, at every single cut, the CT actually overestimated the amount of cement that was actually present. And you can see that on a sagittal view, we got sort of this type of pattern. And this corresponded with the CT scan. So the CT scan actually overestimated the amount of cement that was actually present in the vertebral body. So it's also very sensitive. So this is the right sagittal cut, and then the left sagittal cut. And so this is just sort of an example of how the cement sort of fills. Although this is where the cement fills, you can also see sort of this outline of where the sort of the cavernous trabecular sort of pattern is here relative to the entire vertebral body. And you can see that this is another filling pattern. Interestingly, that was really more anteriorly based with respect to where it's located in zone 1 and zone 2. There's some anterior extravasation, but quite a bit of posterior extravasation through this basivertebral system here. Exactly right. This is the lumbar specimens, axial. Again, noting that the CT scan overestimates the amount of volume of cement. This is right sagittal and then left sagittal. So with respect to the extravasation, this is essentially what we saw. These were the levels where we saw anterior extravasation on the right side at T8, on the left side at these levels, and then posteriorly at these 5 levels. And so we actually took a look at these in detail. The anterior extravasation occurred at these levels. And you can see that in the vast majority of these cases, either zone 1 or zone 2 were almost always involved with anterior extravasations. And with posterior extravasations, you can see that zones 3 and 4 were almost always involved in with these posterior extravasations into the canal. So when we took a look at this, this quadrant system, we wanted to see whether or not there was actually any contact with the cortices at any one of these zones. So what we found out that of those extravasated samples, there was at least some contact. The majority of these actually had some contact with the cortical bone. Those that did not have any extravasation, the vast majority did not have any cortical contact, which makes sense, with a relatively high sensitivity and specificity to this as well, and a very high negative predictive value. So with respect to the spinal canal extravasation, what we are concerned with as spine surgeons, all 5 specimens had either zone 3 or zone 4, and a specimen without zone 3 or zone 4 had no posterior extravasation, as seen here in the zone 4 extravasation into the canal. So when we took a look at the fill rate, we saw a pattern that those that actually had posterior extravasation had a relatively higher filling rate, again, meaning a higher volume over a given period of time. So we saw that anything that was greater than 0.01 fill rate actually had posterior extravasation. So these are the samples that actually had the posterior extravasation. So this is a fill pattern. When you take a look at it from the axial perspective, you can sort of see that as it fills, it respects the cortices and then starts draining out dorsally here. But this pattern really this is where you would put the jam sheeting needle, and I'll demonstrate that when we do the lab demonstration. So it really fills from more anteriorly to posteriorly. But look at this on the sagittal view here, really denoting that this pattern of fill really goes very in line with what happens with a basivertebral venous system. So meaning that here it fills anteriorly, respects the cortices, and it goes to the path of least resistance toward the basivertebral venous system. And then on the CT scan, this was also confirmed as well, this pattern. So again, it's really just more the bony as well as the vascular anatomy of how the cement extravasates into the spinal canal. So some of the patient-dependent factors of the bony anatomy, cement preferentially follows a path of least resistance. It respects the cortices. And the vascular anatomy, it travels through the basivertebral venous system into the epidural venous plexus. So the extracompartmental extravasation of the cement into the spinal canal can cause neurologic sequelae. And some of the physician-dependent factors is the consistency of the cement. So wet cement is more likely to extravasate rather than doughy condition of the cement, and the rate is also very important. The increase in the fill rate may lead to increased extravasation rates. So any fill rate greater than 0.2 cc's per second or 1.2 cc's per minute resulted in posterior extravasation in the study. And the volume, the potential trabecular space dictates the maximum cement volume as well. And we're going to go and demonstrate thoracic. So as you know, the thoracic volume is much less than the lumbar as well. this location is also very important. The anterior localization of the needle is less likely to result in posterior extravasation, although it doesn't mean that it cannot happen. But all posterior extravasation is associated with at least a zone 3 or zone 4 fill. So careful planning and execution really can help to minimize the incidence of these types of extravasations occurring during vertebroplasty or kyphoplasty. But the question is, does it really matter whether you do vertebroplasty versus kyphoplasty? You know, I remember when kyphoplasty first came out with Kyphon, they really tried to market it to surgeons and said it really was a surgical procedure, but does it really make a difference? This editorial came out in early 2000. This is when kyphoplasty, again, first came out. So they essentially said, yet there are still no randomized controlled trials that compare the long-term outcomes of percutaneous vertebroplasty to control therapy. So this was, you know, almost 20 years ago now. And then 2 separate studies came out in the New England Journal of Medicine in 2009. This first one was a multi-center randomized controlled trial of 131 patients randomized to vertebroplasty versus placebo. But essentially, they said improvements in pain and disability associated with osteoporotic VCFs in patients treated with vertebroplasty were similar to improvements in a control group. And then another study, also in the New England Journal of Medicine, also randomized controlled trial, double-blinded, 71 patients this time. Their conclusion was that they did not find any beneficial effect of vertebroplasty as compared with a sham procedure in patients with painful osteoporotic vertebral fractures. And this is just sort of like a review of some of the literature that's out there, both retrospective and prospective studies. And you can see that the prospective studies looking at kyphoplasty versus non-surgical, it does indicate that there was some improvement in the VAS and ODI scores of the kyphoplasty group. And then when looking at kyphoplasty versus vertebroplasty, a lot of the studies don't really show a significant difference between vertebroplasty and kyphoplasty. And in fact, when you take a look at the leakage patterns, it occurred with relative, equal patterns in both the vertebroplasty and kyphoplasty groups. So in reality, is it really worth it? My personal algorithm for doing these types of procedures for patients with compression fractures is if they have tolerable pain, you want to put them into a Jewett brace. If they have intractable pain, then consider a kyphoplasty. If they have no pain after a given course within bracing, then you can DC the brace, obviously. If they have persistent pain, then you can consider doing a kyphoplasty. So in summary, vertebroplasty has its origins to help alleviate tumor pain. That's how it was originally sort of developed. And I think surgeons have sort of gone towards that. To tell you quite honestly, I think surgeons really use this as an adjunct for tumors, metastatic disease, multiple myeloma. Kyphoplasty is a relatively, compared to vertebroplasty, more new procedure. Originally, focusing on surgeons, but I think it really is becoming much more of a interventional radiology and pain type of procedures, especially when it comes to vertebral compression fractures. There are well-documented complications associated with these type of procedures, including pulmonary embolism as well as posterior extravasation, and neither of those are benign, as you know. Previous retro and prospective studies seem to indicate that kyphoplasty was superior to non-surgical treatment, and more recent multi-center RCTs seem to indicate that vertebroplasty versus placebo have equal efficacy. Thank you. Question?
One question about your algorithm. Do you use MR stir sequences to determine whether or not you're still stir positive, or you just go straight to kyphoplasty even after brace fails?
No, I absolutely will get a stir sequence to see whether or not there's actually active involvement, edema within the vertebral body, to determine whether or not it's an active fracture. And I use the stir sequence. Sometimes you can use nuclear med tests, but absolutely use some sort of advanced imaging study to determine whether or not it's an active versus a chronic fracture. Jens?
So, as you know, I kind of went from somebody who was very enthusiastic about cement to somebody who gets near anaphylaxis, but I see it as a necessary evil. There have been reports in the past when we use this as an adjunct to shore up support in our vertebra that saline flush out can try to diminish one of the other causes of problems which we know of, which is fat embolism, so the displacement of pathologic fat globules into the bloodstream. Is that something that you have looked at? Is that something that you would endorse?
I personally haven't used saline, and you're right. There's two forms of emboli that can commonly occur, and one's cement, as I mentioned, but the other is fat emboli. And I think this is all related to the rate at which you're actually delivering the cement. If you think about it, the cement actually pushes out everything that's within that contained space within the vertebral body. So either you can actually extravasate some of the cement to the pulmonary vasculature, or you can actually extravasate what was there before, and that would include fat as well as potentially clot. But no, I have not used saline.
One important thing I wanted to share with the group is, so I still use, when I endorse or augment screw fixation, saline flush out, and I've seen hypotension just from washing out that I always warn the anesthesiologist nowadays, but there's no doubt a bradykinin prostaglandin effect on the vasculature. So these are very complex procedures, and I think the leakage rate is way higher than what we ever thought if we look just close enough. But I think your talk and your studies are excellent to help us understand the difficulty. One other question. So the base vertebral vein exit zones, these one or two large posterior central venous sinuses, is there some merit, is there some way to keep the cement in the zones 1 and 2 in the front to keep away from that?
Yeah, absolutely. And I'm a big proponent of keeping that the cement as anteriorly as possible, because I believe that the anterior extravasations, the sequelae associated with the anterior extravasations are much less than the posterior. So I worry much more. And you saw the studies that show that utilizing intraoperative like X-rays, it's not as sensitive as for instance, what really happens, as well as using advanced imaging studies like CT scans. Thank you.
Let me ask you a question.
Sure.
Just a couple of things. So first of all, should you do this procedure? You're an orthopedic surgeon. So as mentioned here before, you have interventional radiologists, pain management guys, a lot of other specialties are doing this procedure in addition to surgeons. And so it always comes up to, should we get involved in doing this or not? Now, kyphoplasty, surgeons do it, but vertebroplasties are done by a lot of other services. And that's always come up as an issue, especially when you're on call and you get, a patient who's coming in with cement in the canal. I think that osteoporotic fractures who gets vertebroplasty are different than tumor patients who get vertebroplasty. And especially patients with tumors who you're planning on doing vertebroplasty, make sure you analyze the CT scan. Sometimes the back wall is being eaten away, and you look and you see there's no back wall. The body may be a little bit broken, but it looks okay. And then on the CT, there's no back wall there. It's almost like wants the cement to leak there. I do the vertebroplasty. I have one day where I do a lot of them. I mean, we almost can have a 24/7 service for patients with fractures or coming in with tumors. And in my hands, it's an amazing procedure. I mean, the pain relief is immediate. They love it. But you have to stay away from these issues of cement leakage. And so part of the things that we always emphasize is make sure that when you put the needle, it's as anterior as possible to get into the zone 1, zone 2. 2, take your time, right? Take your time. Do it under fluoroscopy. Make sure the cement is thick, like a toothpaste. It's not liquidy. And now some companies are now coming with a thicker type cement. It comes out, it's already very thick. Take your time as you inject it, and don't be rushed into filling the entire vertebral body. We actually don't know how much cement is needed where it's okay to restore mechanical stability to the vertebrae. Some say 30%, 40% is enough. So I'm not sure you actually need to fill up the entire vertebral body. And the time that I stop with injecting the cement is once I see the cement starting marching backward and it gets to the posterior 1/3. Once I see cement in the posterior 1/3, I stop the injection. The issues about kyphoplasty versus vertebroplasty, there's a lot of discussion about which way to go about it. I do vertebroplasties. I used to do kyphoplasties. I don't do them anymore. Part of it is because with vertebroplasty, I only use one needle. And when you put that one needle, just make sure that on an AP, that needle is at the midline or across the midline to the other side, because then you can inject both sides through one needle. It cuts down on the amount of radiation that the patient you get exposed to. And once you get through the pedicle and you're into the vertebral body, medialize that needle, get to the other side, inject on the other side, pull the needle a little bit backward to feel the ipsilateral side. And once you see the cement gets to the posterior one-third, just stop the injection. I've seen a couple of issues where they're now coming with thicker cement to minimize cement leaking backward, and that is that you have to pay attention to the time that you have to walk with it. What you see sometimes is happen, so they give you 12 minutes, and then the cement gets hard. And if the cement gets hard, guess what happened? The needle gets stuck with the cement, and now you can't pull the cement out because that cement becomes hard, and now you got a needle that you can't pull out, and you start moving it, suddenly the entire ball of cement can be moving around. And so just be aware that you have very limited time to put that cement. Put your timer on, and when they say 8 minutes, 9 minutes, whatever it is, make sure that you're able to pull that cement, the needle out. Otherwise, that needle is going to be stuck with that cement. Radiofrequency ablation, do you do those?
I don't. Rod, you had a question?
Just real quick, there's all these studies they quote. So what are both your thoughts on, because I think most surgeons don't necessarily do it for pain. We do it for like deformity, progression, the need for doing bigger surgeries, especially I think in the thoracolumbar junction. What do you guys think about all these papers that they quote in JAMA, New England Journal? They go, okay, placebo is just as good, Jeff.
I mean, those are pretty high quality studies. If you take a look at the Cochrane review, it'll kind of show you a similar type of pattern as well. I think, again, this started off as being pain relief for patients with tumors, right? And so that, it works there. I think what ended up happening is, when Kyphoplasty first came out, we started using them, and we didn't know exactly what the indications were. And so we didn't look at the stir sequence imaging. We probably treated a lot of patients with chronic fractures, and which Kyphoplasty doesn't do much about. So I think if we were much more diligent about doing it on the right patient, it's kind of funny because they tell you to do conservative management with bracing, and if they continue to have pain, then you should do it, right? But by then, these fractures are already healing. So in reality, as we all know, a lot of the patients that do best with these type of procedures for VCFs are ones that when you treat them early on. Like these patients that come in with an acute fracture, you do these procedures and they feel very good because it's a stabilized fracture. So I think what ended up happening is we got a lot of sort of a mix of these acute, subacute, and chronic fractures. And in the chronic fractures, they don't really work that well. So I think that's what ended up happening, sort of kind of muddied the picture a little bit.
Go ahead.
Just one quick question about when you said IR versus surgery, you're talking about fluoro. Are people doing these with CT guidance in the IR suite? Are they doing that? And if so, are there any data showing any difference?
Most of the IR guys and virtually all of the pain guys are using under fluoro, just because of the fact that it's simple. I think it would make some sense to do it via CT, to tell you quite honestly, because of the fact that, again, we're treating vertebral compression fractures which involve the anterior part of the vertebral body, right? And so I think with a CT-guided technique, you could really put it right to exactly where the fracture is occurring. And whereas right now it's sort of done a little bit more blindly, I would say, because of the fact that we're actually just doing it under fluoro. But that's actually a really good point. But I think the vast majority of most people that are doing these procedures are doing it under fluoroscopic visualization.
Related kind of topic for cement placement for following corpectomy, open corpectomy
Yeah.
as a replacement for cage or something else. Are you always just sticking to metformin related? Would you use the same cement, Steinman pin? Can you comment a little bit for the neurosurgeons in particular who aren't familiar with that?
Yeah, it's really interesting because before the advent of interbody cages, surgeons were actually using PMMA in the disc space itself. And then this does work really well as an adjunct to vertebral body replacement. If we really didn't need fusion to occur, PMMA works great, actually, as a vertebral body replacement. And essentially what you do is, we use it quite a bit, actually, in orthopedics when we do total joints. So you get to kind of a very doughy consistency, and you can actually even mold it to sort of replicate the shape of the vertebral body, and then you sort of finger pack it in there. And I know that Jens and Rod have been using this technique of chronic infections, of doing vertebrectomies, and then with antibiotic impregnated PMMA, it works great. So I have a case of my own where we use PMMA, even through an MIS technique where we used little beads, and that does a wonderful job of actually eradicating the infection, using that as a temporary spacer for the vertebral body, and then as a second stage, once they've gone through 6 to 8 weeks of IV antibiotics, you go back in there, take that spacer out, and then put it in a expandable titanium cage or bone, or whatever you want to do. And that's a very effective way of addressing vertebral body defects.
I just want to add a few things. If you think that this is just kind of like a small procedure, it's only going to get bigger for many reasons. I'm now being asked by my radiation oncologist to do prophylactic cement injections. I don't know if you then have this issue, but what happened is you have a patient who have a little bit of a fracture that's a candidate for radiosurgery, and they see fracture related to their stereotactic radiosurgery. About 30% of the time, when they do radiosurgery, the vertebra breaks more. So when they see a little fracture there, they want a prophylactic injection of cement in the body before they do the radiosurgery. And it works great, right? You do the prophylactic, there's no further fracture, you put the cement, the next day they do radiosurgery, done. So the magnitude of these procedures are being used now that more stereotactic radiosurgery is being done, and now it's even pushed further to doing it on patients who may not have fractures. So I actually put some resistance to it to say, if we start doing prophylactic injection on any patient who has a lesion and you guys are planning on doing radiosurgery, we're going to spend all day just doing cement on a lot of these patients. But it's being pushed further and further by radiation oncology. We do not want to see that stereotactic radiosurgery-induced fractures to do prophylactic injections. So I think it's only going to get more and more busy. As to your questions, I use metal methacrylate a lot for transpedicular vertebrectomy in metastatic disease. I do not use pins ever. I've had enough with pins coming into the canal and moving and everything else. So I unlike vertebroplasty, with vertebrectomies, I put in more liquidy, and that thing will fill up the entire space, will fill up end plate to end plate. It's like a perfect fit. You don't even need to mold it before, because if it's liquidy enough, it will fill it up completely, and then just cross-compress it from the back, and it doesn't move. But that cross-compression, you got to be very aggressive about it, and then push on that cement and make sure that there's absolutely no give. You're pushing it, and there's no slight movement. If there's any slight movement, it can back out. So if you do very nice cross-compression, it holds. And then last thing, going to the vertebroplasty, again, going back to, I'm not going to do this, there's not percutaneous, there's now all these cannulated screws that with the elderly population now, with the bones being so weak, you're going to need to learn and be comfortable with knowing how to look at cement. Where is it going? What does it look like on x-rays? And pushing cement through a cannulated screw is not the same as doing a vertebroplasty. It's a little bit different. And part of the issue, if you look at the cannulated screws that are out there, is that the holes where the cement is coming out is both at the tip of the screw, but it's also on the sides of the screw. And guess where the cement comes out first? It comes first to the zone 3 and zone 4 that is mentioned over here. Why? Because the holes in the screw is right at halfway down. And I always said, why? Let's just leave the screw at the tip where you want the cement to come out, but it's actually come out first, at zone 3 and zone 4, because it's halfway down to the length of the. So you have to look at it carefully. And the other thing is the screw is in your way. You don't see the cement as well when you inject the cement through those cannulated screws. So you have to move the fluoro to be able to see where's the cement around those screws. So, dealing with osteoporotic fractures or osteoporosis bone and patients with tumor, you just have to be comfortable with what the cement is, how much time you have to use it. one thing that I really like about vertebroplasties is the inward cannula. So I preload a cannula that already has cement in it, and then I take that cannula and drive it smack through the vertebroplasty needle. So as soon as we turn, cement comes out. I don't need to wait and ask myself, where is the cement, where is the cement as it's coming down the needle. The inner trocar is the one that I'll fill in with cement, and then that needle is always going to be fresh. If something happens, it gets stuck, you pull that needle out, you can put another one in. So that's just a couple of things that I do.